cavity, and the both things have got the highly blood vascular supply. And in the DCR surgery, especially when you doing external DCR, you have to dissect a lot of things like skin, subcutaneous tissue, muscle, lacrimal sac, bone, and finally the nasal mucosa. And our population, nasal mucosa usually is hypertrophic due to atmospheric changes. And when you see the vascular supply over there, vascular supply is more on the nasal side of the orbit. So we have to deal all these blood supply. So main cause of the bleeding is also the oozing. Preventive measures that we can take in three parts: preoperatively, perioperatively, and the postoperatively. Preoperatively, we need to have a good systemic evaluation of the patient, especially we have to control the hypertension if it is their issue, and then we have also to rule out all the nasal pathologies, especially DNS or polyps in the nose. And the blood thinner, this is very important. Most of the patients don't tell about their drug history, so we have to ask about the blood thinner before going for the surgery. These are some contraindications in these cases. IV line should be maintained and mild sedation will help, and anesthesia should be given to the patient. Patient posture should be in reverse trundle in birth position, or head should be raised, not the head only, about 15 to 20 degrees. It can be done under general and the local anesthesia. In even general anesthesia, we have to go for the local anesthesia also to get the hemostasis. This is the method devised by the professor Imran Sahab, and in this we make a cocktail of 5 ml local anesthesia with 2.5 ml of lignocaine and 2.5 ml of bupivacaine, and we mix only 0.1 ml of adrenaline. This provides us a good hemostatic concentration of 1:50,000 ratio. The same ratio is been used to soak the nasal pack. Nasal pack should be of the thin ribbon. It's very important. Otherwise, large thin spaces are not packed properly. And forceps through which we are going to nasal pack should be directed toward the root of the nose, and then packing stock beyond the root of the nose, and the small spaces carefully should be packed, and we have to apply firm pressure, and we have to wait for 5 to 7 minutes before going for the surgery. This is the technique of Sahab. In this, we inject only 0.5 ml in the contralateral depression above the medial pebral ligament, and we make a wheel over there. We don't inject lot of amount of the anesthesia over there. It has to anesthesia the infratrochlear nerve and also provide the hemostasis. Second injection of 0.5 ml or 1 ml has been given in the depression vertically below the medial pebral ligament to anesthesia the nerve coming from the inferior orbital nerve. And the third injection, 1 ml below the medial pebral ligament, 1 centimeter deep to the surface to anesthesia the interior thymoidal nerve. And then we have to wait until we get this blanching. And then we have to go in the layers. Straight away we give incision and reach up to the periosteum. After that, periosteum has to be left. You can observe there is no bleeding at that time, or even oozing. Then entering the suture, making ostium, there is no bleeding, nothing is there. And then reaching the sac, raising the sac, and then opening the sac and the internal caniculi. This is you can see only this bleeding was there. So in external DCR, it's nothing. Patient is again quite comfortable. She's looking at the camera and making the photos for us. Look at that. Even we have used white sheet so that if there is any bleeding, that should be shown on it. So and then this is the postoperative measure. Posture should be there, and we have to remove the pack even immediately or after some time of the surgery. and post nasal antibiotics or nasal decongestion can be given post-operatively. So these are some take-home messages. Nasal packing is so important. If you encounter any bleeding, you have to repack it. Don't use sucker at that time. Thank you very much.
Punctal stenosis and how we deal with it. So, as you know a little bit of about the anatomy, the tears are secreted by the lacrimal gland and flow along the upper and lower lid and enter the puncta, which are present on the medial aspects of the eyelids, upper and lower, and then pass into the canaliculi and the common canalicus sac and then the nasolacrimal duct. So the punctum itself is present on the papillas and they are at the posterior edge of the lid margins. They're about 0.2 to 0.3 millimeters in diameter and surrounded by a fibrous ring to keep them open. Upper punctum is about 0.5 to 1 millimeter medial to the lower punctum and the eyelids are opposed to each other. The papillae are surrounded by muscles of Raylan and they pulled medially and posteriorly when the muscle contracts, which is the part of the orbicularis complex. The incidence of punctal stenosis is still unknown, but is reported between 8 to 54%. So what are the causes of a watering eye? Either there is hypersecretion or there is defective drainage. So hypersecretion can occur as reflex from dry eyes or due to any cause of inflammation on the surface of the eye. Defective drainage is ectropion, where the punctum is turned away from the eye itself, or there is obstruction anywhere in the nasolacrimal drainage system, or there is a lacrimal pump failure, which the example is a facial palsy. So what are causes of acquired punctal stenosis? A huge list, but mainly it's involutional or chronic inflammatory conditions like blepharitis, secretory pemphigoid, graft versus host disease, dry eye syndrome, or eyelid malposition, which has been present for some time. One of the most important causes are the chronic use of topical medications. This is one of the most common causes of punctal stenosis that we come across. Other systemic medications like 5-fluorouracil, hydroxyuridine can cause it, peripunctal tumors, certain systemic diseases, or peripunctal tumors. So one of the ways to manage it is perforated punctal plugs. So I'll just show you this movie, how we use it. So you dilate the punctum with a punctum dilator, and you need to dilate it quite vigorously so that the plug can be placed easily. And these plugs are available in various sizes, so you can sort of order according to what the punctum looks like, either small, medium, or large. So once the punctum the upper flange should sit outside the punctum, and this is perforated so that the tears drain through it into the canalicular system. The other way to manage it is by punctal snip procedures. You can do a 1-snip, 2-snip, or a 3-snip procedure. I am mainly an advocate of 2-snip punctoplasty, where you make a vertical cut in the medial and the lateral wall of the vertical part of the canaliculus, and then remove that posterior wall of the vertical canaliculus, the first 2 millimeters. So I'll just show you a small video of that. Again, you give a little bit of local anesthetic under the canaliculus, and then on the conjunctival side, you can see the punctum is closed at the moment. Again, you dilate the punctum. Again, you need to dilate it quite vigorously, so that, and then you just syringe to make sure that nasolacrimal duct system is patent. And you make a vertical cut on the lateral wall of the canalicus, then a vertical cut on the medial side, and then remove the posterior wall of the vertical part of the canalicus. Little bit of bleeding, but you don't need to cauterize it. You just need to give a little bit of pressure and the bleeding will stop. So this allows the epithelium of the punctum to heal and the punctal opening to get enlarged. So another way of doing it is by Kelly's punch. Again, in the initial steps are almost the same. Once you syringe and make sure that the punctum is the nasolacrimal duct is open, then you again dilate the punctum vigorously, and then use a Kelly's punch to remove the posterior wall of the vertical canalicus. You can use this punch. It cuts very nicely, and usually the bleeding is much less in this procedure. So you can make about 3 or 4 punches to make the opening larger. Thank you very much.
बेसिकली ये इसलिए ब्लॉक हो जाता है कि ये कैनलाइजेशन नहीं होती है पिछले कॉर्ड की, ठीक है ना जी, और तकरीबन नियर बर्थ आगे पूरा कैनलाइज होता है।
सो ये
तो अगर ये थोड़ा सा आगे पीछे हो जाए,
ये स्लाइड चेंज करो,
वो ब्लड चेंज मैं करूँ, चलो
मैं कर
कोई नहीं, मैं कर लूँगा। सो 6 months पे तकरीबन 60% होते हैं और 90% by the age of 9 months। इसलिए भी wait for them to canalize themselves rather than doing it before। ज़ाहिर है उसके अपने प्रॉब्लम्स भी हैं, तो उनको अवॉइड करने के लिए तो बहुत कुछ वहाँ पे हो सकता है। इट कुड बी सिंपल मेम्ब्रेन, इट कुड बी सिंपल कॉर्ड ही पूरी की पूरी मौजूद है या बनी नहीं हुई, या मनी ए टाइम्स इट्स अ बोन ही ब्लॉक होता है। तो मसाज क्यों करते हैं, कोई बताएगा? क्यों बता भाई? हाँ, और मैं नहीं देखने दूंगा, बता। देखो एक बहुत बड़ी रीजन जो है, अब दिस बहुत बिग रीजन, यू डेली एम्प्टी द सैक 3 to 4 times so that no infection develops। आप नहीं भी खोल सकते तो ना खोलो, यू एम्प्टी द सैक and then immediately put in an antibiotic ताकि सैक उसको सक कर ले और आपको सिस्टेमिक एंटीबायोटिक देने की जरूरत ना पड़े, ठीक है ना। सो इसका ख्याल है कि हम सैक को इसलिए दबाते हैं कि सैक में प्रेशर बढ़े, जब सैक में प्रेशर बढ़ेगा तो nasolacrimal duct में प्रेशर बढ़ेगा, और उसमें प्रेशर बढ़ेगा तो इफ देयर इज सम मेम्ब्रेन तो मे बी वो स्ट्रेच करके टूट जाए। सो मसाज कहाँ करना होता है, किसी को पूछें, फेलोशिप करके आए हुए, मैं भी सीखूं इससे।
Zishan is in the line of fire.
शाबाश,
At the medial canthal ligament.
शाबाश।
The sac lies immediately behind.
और कहाँ पे?
Or sir, be directed towards the.
और कहाँ पे होता है? और वो तो सामने होती है ना, बाकी उसके इर्द क्या होता है?
sir.
इसकी
Canalicular.
जरूरत क्यों पड़ी तुम्हारी मदद की? वो बहुत बड़े गुस्से से देख रहे हैं। हाँ, पीछे लेक्रिमल फॉसा होता है, सबसे बड़ी चीज़ है, इसके आगे लेक्रिमल क्रेस्ट होती है। सो हाउ डू यू टेल द पेरेंट्स के कैसे करना है?
So we have to demonstrate them.
कैसे?
Sir, सबसे पहले तो we tell them.
शाबाश, ऊंची बोलो।
We tell them to.
बिल्कुल कॉन्फिडेंट बेटे।
ہاتھ صاف
کوئی ساری ایک فنگریاں کوئی وہ نہیں کر رہا. ہاں ہاتھ صاف کرے اس کے بعد
سر میک شیور دا بیبی از کمفرٹیبل.
وہ سب ہو گیا. اب دبائے گا کہاں پہ؟
اس کے بعد دبانا ہے سر میڈیل کینتھس کے اوپر, جسٹ ایٹ دا میڈیل کینتھل ٹینڈن, اینڈ پریس اٹ.
ٹینڈن اتنی نرم ہوتی ہے کہ اندر چلی جائے. ٹینڈن اتنی نرم ہوتی ہے کہ اندر چلی جائے.
ٹوورڈز دا
چلی جاندی ہوگی کمزور ہو گیا. ہوتی ہے. ہاں ہوتی ہے. اچھا ٹھیک ہے, اس کو کہہ نہیں سکتے ہیں. اور ٹھیک ہے بیٹا ٹھیک ہے.
اور ٹوورڈز دا نیزولیکریمل ڈکٹ.
نہیں اس کو کیا بتاتے ہیں
سر ایل آف دا نوز, ناک کے باہر.
نہیں یار والا چھالا نہیں ہوتا. دیکھو بات سنو, پہلے تو اس کو بتاؤ چھوٹی انگلی انگوٹھے سے کرے گا, انگوٹھے سے کرے تھے, انگوٹھے سے کرے گا. پہلے تو چھوٹی انگلی دکھا.
سر چھوٹی انگلی یا کاٹن بڈ بھی یوز کر سکتے ہیں.
کاٹن بڈ یوز کر سکتے ہیں.
دوسرا ہم یہ بتاتے ہیں کہ جسٹ میڈیل کینتھس آپ وہاں دباؤ جہاں سے سیکریشن نکلے. یہ بھی ایک آئیڈینٹیفیکیشن پوائنٹ ہے.
کینڈن کے نیچے سے جاؤ تو یو کین گو انٹو دا فورسا. میں تم کو دکھاتا ہوں کہ تم اپنا دیکھ. سو لیٹسٹ فنگر, اور اس کو میں اب دیکھ رہا ہے. تو اس کے بعد اس کو میں میڈیل کریسٹ دکھاتا ہوں اور اس کو بتاتا ہوں یہ دیکھو یہ خالی جگہ ہے. کہتے ہیں ہاں یہ خالی جگہ ہے. کہ یہ جگہ اٹس این ایمپٹی اسپیس دیر. وہ بھی آج دیکھ رہے 40 سال کے بعد. دیکھو یہ چھوٹی چھوٹی باتیں ساری میں ہم غور نہیں کرتے, اور اس کا نتیجہ یہ میں نے 25 اکٹھے کیے ہیں اپریل میں بھیجے, وہ 4 ہی ملے 4-5. تو اس طریقے سے اس مساج ہوگا. اور پھر ان کا خیال ہے کہ ہم نیزولیکریمل ڈکٹ کو مساج کر سکتے ہیں. ہاں وہ بون کے اندر ہوتی ہے, وہ بون میں ہوتی ہے, میڈولا کے اندر ہوتی ہے. وہ کیسے کر سکتے اس کو لگے گا اوپر سے نیچے. اب کیا سلطان صاحب اچھا سو اس کو ہم وہ نہیں کر سکتے نا. بہائنڈ دا میڈیل کریسٹ, اس کو میں میڈیل کریسٹ بھی دکھاتا ہوں. میڈیل ٹینڈن کے نیچے سے اس کو دکھاتا ہوں کہ دیکھو خالی جگہ ہے, اس کو دباؤ. تو اس سے وہ جو ہے ریگرجیٹیشن ہو جاتی ہے. اچھا جی. سو یہ میرے سارے ڈائیگرام رات کو گم ہو گئے تھے, میں رات کو بیٹھ کے بنایا. بیسیکلی یہ کریسٹ ہے, یہ فوسا ہے, یہ ناک میں جا رہی ہے, دیٹس دا کینالیکولس. سو پریس ہینڈ. ٹھیک ہے ٹھیک ہے ہاتھ ہے نا یار. یہ دیکھو یہ ہماری وہ ٹینڈن ہے, یہ بون کی وہ مارجن ہے. یہاں سے ہم جا کے نیچے سے تو اس کو پریس کر دیتے ہیں. یہ اوپر سے بھی ٹھیک ہے, لیکن نیچے سے آپ بالکل اس کو ڈیپ جا کے کر دیتے ہو. ٹھیک ہے نا. دس از دا پلیس ویئر یو پریس. کتنی دفعہ پریس کرنی جی؟ تیری باری آئی ہے. کتنی 3 to 4 times a day. 5 to 10 times تو پمپ رہا ہے. ایک دفعہ دبا دو بس زور سے.
3 times also enough.
بہت ہے. بار بار دباؤ تو اس کو پریشر ہی نہیں بنے گا, تو نکل جائے گا سارا کچھ. تو پریشر بنے گا, پریشر جو بنا ہے اس کو نہیں دبانا نا آپ نے, اور اس کو خالی کر دینا. اینی وے تو ہم کیوں کرتے ہیں پروگرام؟ ہاں تو یہ بڑی دفعہ ایکسکیوز کیا میں نے.
سر آپ جو کہہ رہے ہیں کہ
ہاں بولو
وہ کامن کینالیکولس ہے وہاں رکھ کے, تو ریگرج کر جاتا ہے.
ہم تو
اپر اور لوور کینالیکولس کو لے کے ساتھ ایسے دبائیں.
کینالیکولس کو تم دبا ہی نہیں رہے.
نہیں فنگر اتنی موٹی ہے نا سر.
نہیں چھوٹی چھوٹی لا نظر اپنی ہے نکتا
جی سر.
ایک آدمی اوپر دیکھو, یہ دیکھو اندر گیا اور خود سے دیکھنے آ رہا ہے.
سر دوسرے یہ کہتے ہیں کہ مدر فیڈ کے دوران دبائیں. دیر از نیگیٹو پریشر ان دی.
اگر باپ کھلا رہا ہو تو پھر
نہیں سر, باپ کبھی بچے کے پاس نہیں ہوتا, ماں ہی ہوتی ہے.
تم نہیں ہوتے نا, ہم سوچتے ہیں. بات یہ
سر نیگیٹو پریشر ہے.
میں ان کو ایڈا نیگیٹو نہیں ہوتا کھانا. میں یہ کہتا ہوں کہ جو بائی دا چائلڈ سلیپ, تاکہ سر مارے تو آنکھ کو نہ لگے. میں یہ انکریج کرتا ہوں. یہ چھوٹی باتیں نہیں ہوتی, وہ ہاتھ ہی دھوتا رہے گا بس, تو ہاتھ دھلاتا رہتا ہے, اور سر کو پیچھے سے پکڑنا ہے. You have to tell the patient and the parents how to do it. ٹھیک ہے نا. سو ہاں کیوں کرتے ہیں وہ بتاؤ بڑے پڑھ رہے جلدی جلدی کیوں پروبنگ کیوں کرتے ہیں؟
تو ٹو چیک کے بلاک کس جگہ پہ.
شاباش وہ پڑھ دیتے ہیں. اور
سیکنڈلی ٹو اوپن اٹ.
اگر کوئی کھول سکتا ہے تو کھول دو, ورنہ اس کا مین پرپز ہوتا ہے ٹو فائنڈ آؤٹ ویئر دا بلاک از. ابھی ہمارے تقریباً 99.9% ریکارڈ ہوتا ہے MLD بلاک, تو بیکار ہے, آپ کو دوبارہ کرنی پڑتی ہے پروبنگ جسٹ ٹو ڈائگنوز اگین. تو اس کا آسان طریقہ میں نے تو رکھا ہوا ہے, میں یہ ڈائیگرام بناتا ہوں اور جہاں بلاک ہوتا ہے بلاک کو ڈرا کر دیتا ہوں. I just draw it. I don't write down. اور جہاں بلاک ہوتا ہے اس کی نیچر لکھ دیتا ہوں. ممبرینس بلاک, اوور کم اور ناٹ اوور کم. بھونی بلاک وہاں پہ لکھ دیا. نیرو ہے پیسے تو اس کو نیرو بنا دیا تاکہ ایک نظر میں اگلے کو پتہ چل جائے. پتہ نہیں یہ چیز آج تک کامن کیوں نہیں ہو سکی, پورا میں نے زور لگا دیا. بہت چیزیں میں نے انٹروڈیوس کرا دی لیکن یہ میں نہیں کر سکا. ڈھونڈ کھانے کی بڑی سیدھی سی بات ہے. سو تم میں سے ڈسکو الاسٹک کون یوز کرتا ہے؟ تم لوگ کرتے ہو؟ تیری سے ساری میرے شاگرد ہیں. So that's my method of doing it, using the viscoelastics. I use viscoelastic before I probe. So I dilate the punctum, pushing a little bit of viscoelastic, and then do probing till the lacrimal sac. And when you reach the lacrimal sac, I go again, pushing some viscoelastic and go through the nasolacrimal duct. ٹھیک ہے نا, یہ آ جائے گا. ابھی آتا ایڈریس سے لینے ہی گئے میں پتہ تجھے بیٹھے ہو. یہ کیا آ گیا؟ اچھا ایک منٹ, میں نے لکھا تھا یار, کدھر چلا گیا؟ واقعی آپ نے اچھا کیا پوچھ لیا. سوری وہ سلائڈ غائب ہو گئی. اس میں نمبر 1 اس کا فائدہ ہوتا ہے لیبریکیشن. اٹ ہیلپس. آپ دیکھیں گے بڑی آسانی سے پروب اندر چلی جاتی ہے. دوسرا کیا ہوتا ہے کہ ایسے انجیکٹ وسکوالاسٹک کئی جگہ پہ پیسیج ہوتا ہے کولیپس ہوا ہوتا ہے, اینڈ وین یو گو اینڈ یو ٹرائنگ ٹو ڈو گیٹ اے فاسٹ پیسیج, سو اٹ سالوز دا ڈسٹینس, اور آپ کا پروب آرام سے چلا جاتا ہے. آپ کو کنک نہیں ملتا, سیدھا ملتا ہے. جس کی بھی ہو وہ کی ہوتی ہے. تو آپ گاڑی میں بھی آپ تیل ڈالو, میٹل لگے بھی نہیں, واٹر انسائڈ نہیں ہوتا. واٹر نہیں, اب تم لڑ رہے ہو لوبریکینٹ. آئی ایم یوزنگ اٹ ایز اے لوبریکینٹ. آپ کریں نہ کریں آپ کو کون کہہ رہا ہے؟ سو اٹ ہیلپس. آپ ڈفرینس دیکھ لیں گے, وین ایور یو ڈو یو سی دا ڈفرینس. اور جو ڈسٹینشن ہوتی ہے اس سے ڈیفینیٹلی فائدہ ہوتا ہے. آپ کو پیسج ملتا ہے کس طرف جانا ہے اس میں, ٹھیک ہے نا. اور تیسرا اس کا فائدہ یہ ہوتا ہے کہ کوئی چھوٹی موٹی ابسٹرکشن ہو, دیٹ از اوور کم ود دا ہائیڈروسٹیٹک پریشر آف دا ڈسکو. پانی سے اتنا ہائیڈروسٹیٹک پریشر نہیں بنتا ہے جی. پہلے ابھی نہیں پہنچے گا. سو یہ ہو گیا. یہ دیکھو پروبلم جو ہے, یو ٹرائی ناٹ ٹو کریٹ فالس پیسیجز, نمبر 1. نمبر 2, upper canaliculus is the better one because it is more in line with the passages, ٹھیک ہے نا. دوسرا, once you have reached the spot, you do it with increasing diameter. اور چوتھی بات کیا ہے کہ I advance it into the lacrimal duct which reaches the floor of the nose. ٹھیک ہے, اب وہ کیسے پتہ چلے گا فلور آف دا نوز میں پہنچ گیا؟ How would you know it? ہارڈ ہوگا اور وہ بڑا آسان رکھا ہوا ہے. Once it stops there, I hold the probe at the canaliculus, take it out and just compare with the external. اس کو میں کمپیئر کرتا ہوں تو آپ کو فوراً پتہ چل جاتا ہے کہ یہاں سے لے کے یہاں تک پہنچا ہوا ہے, ٹھیک ہے نا. جسٹ آپ پروب کو ایسے کر کے نا اوپر سے پکڑ لیے جہاں سے وہ نکل رہا ہے, اور اس کو جا کے یہاں رکھ دیا, آپ کو نظر آ جاتا ہے رائٹ اپ ٹو دا فلور آف دا نوز. ٹھیک ہو گیا. اچھا, سو یو آر ناؤ ان دا نیزل فلور. ضرورت نہیں پڑی کبھی. اچھا یہ دیکھو, آپ جب اس کو انجیکٹ کرتے ہو نا, یہ ایکسوڈیٹ وغیرہ ایک طرف چلے جاتے ہیں. یہ ڈسٹینڈ ہو گیا, یہ دیکھیں یہ بلاک تھا میمبرین کا, وہ بھی ڈسٹینڈ ہو گیا. ٹھیک ہے نا. تھیوریٹیکلی یو کین انڈرسٹینڈ کہ کیا ہو رہا ہے. یہ ایکسوڈیٹ بھی ایک طرف چلے گئے سارے, اور اب یہاں پہ آپ پہنچ گئے. اینڈ دین یو بریک دا بلاکیج اینڈ یو آر ناؤ ان دا نوز. ٹھیک ہے نا, یہاں پہ آپ آ گئے. اب اس میں امپورٹنٹ کیا ہے, اب بلیڈنگ بھی تھوڑی سی ہو گئی, سو پروبنگ بھی ہو گئی. ناؤ once I reach the floor of the nose, I take the viscoelastic in the syringe, اس کے آگے کینولا لگا کے I pass the cannula right up to the nose, and while coming out I inject the viscoelastic, not while going, coming out. وہ کیا کرتا ہے, یہ دیکھیں, when I reach the nose I start injecting and just pull out the needle. Ab what does this viscoelastic do? It pushes all the membranes, all the blood, all the exudates towards the wall of the nucleus. اس کو ڈسٹینڈ, ہاں جی وہاں روک دیتا ہے. They don't fall back. یہی اچھا, this also acts as a tamponade to stop bleeding. ورنہ بعد میں وہی تھوڑی سی بلیڈنگ, وہی تھوڑا سا ایکسوڈیٹ, وہی تھوڑا سا میمبرین, they come back into the passage. So یہ 2-3 دن رہتا ہے اور 3 دن میں وہ وہاں پہ جڑ جاتا ہے. یہ بہت بڑا اس کا ایڈوانٹیج ہے. جی بیٹے, ہمارے وائٹ بورڈ جتنے آپ کی پروب ہوتی ہے نا, ایسی نیڈلز ملتی ہیں لانگ نیڈل, جی کو آپ پروب کے رستے پہ ڈال کے ایز یو کمنگ آؤٹ یو اسٹارٹ انجیکٹنگ, اٹ کیپس ایوری تھنگ ان پلیس. ٹھیک ہے نا. سو یہ دیکھا آپ نے, یہ والا افیکٹ, یہ سارے ایکسوڈیٹس, میمبرینس, بلڈ, یہ سارے کا سارا وال کے ساتھ لگ جاتا ہے, وہاں پہ اسٹک کر جاتا ہے. ٹھیک ہے نا. اچھا یہ یہاں پہ آ گیا, سوری یہ وہ والی سلائڈ تھی. ٹھیک ہے نا. سو ایز وی فائنلی فل دا nasolacrimal passage, all the broken membrane, blood وغیرہ, they just are pushed against the wall. سو اس کا ایک اور بھی فائدہ ہے, prevents further bleeding. It is contrary to water, it does not enter the false passages. thick ہوتا ہے. What happens is if there is false passage and we inject water, it enters the false passage, اس کے wall کو lift کر دیتا ہے, block کر دیتا ہے, plus infection spread ہو جاتا ہے. یہ جو ہے یہ اس کو false passage میں enter نہیں کرتا viscoelastic جو ہے. سو سمجھیں کتنے لوگ کرتے ہیں پروبنگ کے بعد؟ کوئی نہیں بول رہا ڈر کے مارے. تو why do we do syringing? ہے کیا کہہ رہے سلطان؟ دیکھیں اس میں 2-3 باتیں ہیں. once you have entered the nose, you know it is patent. ٹھیک ہے نا جی. دوسرا, اگر آپ اس کو واش کرتے ہیں تو جتنا ڈیبری ہے یہ پھول جاتا ہے سارا. ایسے تو نہیں واش تو نہیں, بہت سارے میمبرینز ہوتی ہیں اس میں, بہت سا کچھ. سو دے ٹینڈ ٹو سارٹ آف فالس پیسیج میں بھی انٹر کر جاتا ہے, انفیکشن بھی پھیلا دیتا ہے. ٹھیک ہے نا. اور موسٹ آف دی ٹائم ہم کب انجیکٹ کرتے ہیں, پورا اندر ڈال کے ڈائریکٹلی انٹو دا نوز, تو وہ تو بیکار ہوتا ہے. ٹھیک ہے نا. What I have found is کہ اس کی ضرورت نہیں ہے. I never do syringing with water. وہی viscoelastic انجیکٹ کرتا ہوں and it just pushes everything, debris, blood, extra towards the wall and that's it. اچھا آپ نے syringing کی, اس کے بعد بلیڈنگ پھر ہو گئی. بلیڈنگ تو ہو رہی ہے, اوزن ہے. ٹھیک ہے. viscoelastic جو ہے وہ tamponade کا کام کر رہا, so it prevents further bleeding. اور جب سے ہم نے یوز کرنا شروع کیا ہمارے بہت بہتر ہو گئے, بہت بہتر ہو گئے. significantly. ठीक है ना? So what the first person it will hydrate broken membranes and blood will still lose and sort of even after washing. So it's just false sense of security. जिस हम कैनालिकुलस के अंदर वो डाल देते हैं 1 मिलीमीटर की सिलिकॉन ट्यूब और वो इतना मोटा 150 मिलीमीटर का जो पैसेज है हमारा ख्याल है 1 मिलीमीटर ट्यूब उसको खुला रखेगी. फॉल्स सेंस ऑफ सिक्योरिटी है ना. सिंपली दिस इज अ फॉल्स सेंस ऑफ सिक्योरिटी. सो हमारे 60 से 80% इसका रिजल्ट हो गया. प्रोसीजर itself has become very easy. So इसका purpose was कि number one we should be all following reason where to press or why are we pressing and when we are doing probing why are we doing the probing, what's the purpose. हमें most of the time हमें पता नहीं होता. ठीक है ना. We want to know the exact location और हमने लिखी नहीं होती रिजल्ट के ऊपर कि कहाँ पे है. We don't write और लिखना मुश्किल भी है कि कहाँ पे करके. So अगर आप ड्रॉ कर दें तो इट्स वेरी इजी टू. ठीक है ना. और बाकी इम्पोर्टेंस ऑफ विस्को इलास्टिक ये मैंने स्टार्ट किया और इसका काफी सारा जो है फायदा हो गया. सुल्तान साहब अंग्रेजी में शेर पढ़ रहे हैं ना. क्या शेर है. बक रहा हूँ जमीन में क्या क्या कुछ तो समझे खुदा करे कोई. सादिया कहती है ऐसे नहीं है, ऐसे नहीं है. तो कोई सवाल, एनी क्वेश्चन?
Failures of doing probing, and do you embark for the DCR or you have the option of doing the in-fracture of the inferior turbinate? Do you have the experience of that?
इसमें डिपेंड करता है कि आपने जो प्रोबिंग सिंगिंग की थी हाउ डिड इट गो. अगर आपका प्रोब टाइटली गया है तो दैट शोज के पैसेज है. अगर आपका प्रोब बिल्कुल पास नहीं किया, प्रोब हैवंट पास, इट मींस देयर इज अ बोनी ब्लॉक दैट वुड डेफिनेटली नीड अ डीसीआर. बट इफ इट इज यू नो कि पैसेज इज देयर, वो बंद हो जाता है दोबारा सॉल्व होके, तो आप वो भी कर सकते हैं, क्लोज इंट्यूबेशन भी कर सकते हैं. That is one. The other one is closed intubation.
If there is a bony obstruction that you feel, then in fracture of the inferior turbinate is helpful, and it can be tried, and it is successful in certain patients. But not always. If it is a very strong bony obstruction, then the only recourse is DCR. If there is repeated failure of probing, but you don't feel a very strong bony obstruction, then you can try intubation of the closed intubation of the nasolacrimal duct, and that is successful in most cases if there is no strong bony obstruction.
Especially अगर वो आपका चला जाता है अंदर.
I don't think we should resort to a turbinectomy, but you just infracture the inferior turbinate by either a hemostat or just using a free periosteum elevator and elevating the inferior turbinate medially and upwards. Okay?
Beforehand we go for laser examination.
Yeah.
We come to know there is inferior turbinate.
Bring up some.
आखिरी दफा जो एक तो पहले किया था वो तो शुरू में पंक्चर को डायलेट करते हैं, कैनालिकस को किया, कैनालिकस के आगे जाते ही फिर दोबारा करते हैं. जब आप वापस आए उसके बाद जब आपने प्रोग्राम किया अब आप उसकी जगह फ्लो की जगह नीडल को पास करेंगे, and as you are coming out you start
I think we should move ahead. We are running short of time. Excuse me, sir.
Sir, मैं कहना अभी we move ahead because there are a lot of speakers and
Thank you, sir, for introducing
Assalamualaikum. I am Dr. Sidra Anwar Rana. I am a fellow at McMaster with Dr. Yasir Khan, doing my ophthalmic plastic reconstructive and orbital surgery. Today I'm going to talk about canalicular reconstruction and the techniques that we're currently using over there. So I think we've already gone through all of this in the previous lecture, so we don't have to go over them again. The only thing that is important is just the canaliculus. I would want to say it's kind of like the Pandora's box of the lacrimal system in terms of its small size and the trouble it brings us. The clinical challenge in canalicular obstruction is usually having as close to physiological function as we can achieve after the reconstruction. So there are multiple causes of canalicular obstruction, which again have been discussed before, so I'm not going to go into the details of them. For pre-operative assessment, we usually start with the probing and irrigation of the canalicular and the lacrimal system. This gives us a good idea of whether there's a hard stop or a soft stop in terms of whether there's just an NLD block or a canalicular block as well. It also quantifies the canalicular patency in terms of the stenosis and at what part of the canaliculus the stenosis is present. Imaging can also be used, but it's less commonly utilized. So the surgical philosophy behind canalicular reconstruction, like I said before, is restoration of physiological tear flow. It can either be done by meticulous canalicular repair where possible or an effective durable bypass. In cases of canalicular laceration, usually if it's a unicanalicular laceration, we can just primarily repair and place a stent in there. It can be unicanalicular or a bicanalicular stent depending upon the kind of laceration that we see. So in proximal, if we try to define the canalicular reconstruction, it can either be proximal, distal or mid-canalicular, and that kind of defines how we're going to approach the treatment or the strategies that we have. For proximal canalicular obstruction, the different techniques that are currently being used are canalicular or lacrimal de-roofing, canalicular marsupialization with or without a stent, and the stents that we use are usually mini Manoka, or we can sometimes alternate if it's not present with a 20 gauge or a 22 gauge IV cannula or an angiocath. For mid-canalicular obstruction, most of the time we're just left with the Jones tube or the conjunctival dicryocystostomy. For distal canalicular obstructions, that means it's closer to the common canaliculus. Usually, what we can do is use trephinition to open up the canalicular obstruction, and it can be combined with a DCR to give a better result, or it can be done on its own as well. Laser recanalization can also be used for distal canalicular obstruction, but it has limited value. And then the last resort, that's Jones, is an option for all kinds of canalicular repairs. So for lacrimal de-roofing, I don't know if it's a very commonly performed procedure. I've never done it personally myself. I just came across this when I was studying for this talk. But there is a study by Hamake in 2025, and he reports 80 to 85% success. It's kind of like doing a two-snip punctoplasty, but you're opening up the roof of the canaliculus in this case. So this is a technique that we've currently used with good success rates. It's canalicular reconstruction with marsupialization of the canalicular epithelium. We use tenone nylon to do the marsupialization of the epithelium. It can be augmented if required with a stent, which can either again be mini Manoka or a 20 gauge or a 22 gauge IV catheter or an angiocath. If it's a recurrent stenosis, canalicular stenosis, or if we feel that it's going to be progressive, we can use MMC as well in that area. The application is similar as we do for the glaucoma surgeries, but it's followed by aggressive irrigation, of course. So we've had 90% success rate in simple proximal blocks with this technique, and the success rate has improved with the augmentation. So this is an image of the angiocath that we're currently using. It has a retractable needle, which kind of helps us come out easier. So the trephination of the canalicular system can either be done with a lacrimal or a canalicular trephine. There are multiple kinds available, but they're not used that often and they're not available in all facilities. So what we've done in its stead is that we use angiocath like this to use as trephination. So I'm not sure if the image is too clear over there, but the sleeve of the catheter exposes, there's a small tip of the needle that's exposed at the top, and that is what we're using as the trephine over here. So we've had 95% success rate with this procedure. We leave the catheter in trim to size for the canaliculus as the stent at the end of the procedure. Complications, of course, there is chances of extrusion of the stent, and we've had a few cases in which there is recurrence of the stenosis after stent removal. We're leaving the stent in from 4 to 6 weeks at this point, but we're still looking at like if we need, we can increase the time as well. So some modifications that we're trying to make is for one thing, prolonged stenting, like I said before, and MMC irrigation of the lacrimal passages, but we haven't started this yet. We're still looking at it because there isn't a lot of research available on the systemic absorption for that and the side effects related to that. So these are a few images showing the procedure that I just explained. The angio catheter, after doing the 3-snip punctoplasty, we just, not sorry, 3-snip, just 1-snip to open up the canalicular roof, and we enter the angio catheter in. The second image is showing the catheter in place and the needle has been retracted. The third image over here shows the catheter has been trimmed in place into the canalicular lumen, and the ostium has been opened up by marsupialization of the epithelium with a tanno-nylon stitch. So this is a small video showing the way that we trephine. So this patient had a proximal canalicular block at around 3 mm or so. And once we're able to get through, we irrigate to make sure that there are no false passages and we're in the actual lacrimal system before placing the stent in, before leaving the stent in. All right, so I think I skipped a few things, I'm sorry. Yeah, so of course after that, if all else fails, we have to resort to the last resort, and that's the canalicular DCR. There have been multiple bypasses suggested, but Jones tube remains to be the gold standard for a conjunctival recryocystocystostomy. This gives us the most physiological bypass that is possible. So Jones tube, like I said before, it's the last frontier in terms of canalicular block. The success rate is 80 to 85% in terms of drainage in the long term, and 50 to 60% of the patients might need readjustments in the early post-op period. Complications that we've seen are granuloma formation, tube migration or dislodgement, revision surgery, like I said before. The maintenance of the tube is a little bit difficult for the patients, so they have to be counseled clearly about that. And some patients might be dissatisfied as to the results of the surgery. So these are two of our patients with successful Jones tube placement. As you can see, the Jones tube present at the medial canthus area. This is a coronal CT scan showing the Jones tube in place in the left orbit, going through the lacrimal bone over there. So these are a few other procedures that have been tried, but they're all of limited value: balloon canaliculoplasty, endoscopic assisted canalicular recanalization, and canaliculoplasty and laser recanalization. So all of them have limited value in terms of the area that they can cover and the success rates that they offer. And I guess this is it for me today. And if there is any question.
This symposium and I am presenting my talk on how to make a successful endovasal DCR. I am the keen learner of endoscopic DCR since many years. So I have gone through all the complications which come across any surgeon who is doing DCR. So what is the successful DCR? You know, endoscopic DCR has some extra advantage to external DCR. With doing the DCR with endoscopes, it gives extra magnification, extra illumination, and you identify all the anatomical structures. You can handle all the difficulties which come across during the surgery, and you can accurately metabolise the sac. That is the important step in the successful DCR. What is the successful DCR? So if you put an endoscope in the nose, you see a widened neosteum, and when you press the middle canthus, the remnant portion of the sac is visible. There is a hassle-free drainage, and patient is free of symptoms and wide osteum on the nasal endoscope. This is the successful DCR. We are all well familiar with the indications of DCR, and it may be congenital, it may be acquired, but I will share a unique indication for DCR. So a few months back, a young lady came to me, and she was candidate for DCR, and she talked to me that I have marriage in the end of Feb, but she is delaying her marriage for the last 2 years due to this epiphora, because her makeup washed away due to the excessive lacrimation. So I did her DCR. So this was the lady, and this is a unique indication. I don't know this is indicated in the literature or not. And so how you proceed for DCR? Obviously diagnostic, probing and stringing. This segment is lacking in ENTs, and all the patients are referred from eye surgeons. They do the stringing and probing, and you can say if the patient has problem distal to the canaliculi, or you can say if the patient has hard stop on probing, it means this patient is candidate for the DCR. If there is a soft stop, and it means the problem lies somewhere here, and he or she is not candidate for DCR. So this is the right indication for doing the DCR. Some clear patients who have regurgitation positive. So such patients don't need any stringing or probing. You can do straightforward DCR surgery in these patients. So this is my patient. So this is a clearly regurgitation positive. In the literature, the following causes are mentioned that causes the failure. This is the first important one, is the bleeding. Bleeding is the single most factor that affect your results, because all the landmarks are not visible, and your VM is distorted, and you can't perform the successful surgery. Other causes of failures are inadequate bone dissection, deficient sac metabolization, nasal adhesions. If you do a very good DCR, but due to the trauma on the sinonasal mucosa, later on there is a adhesion formation, so that block the neosteum. How do I do it? So I will present my steps of surgery, and I hope so it will give some benefit to your daily practice. There is a saying from Abraham Lincoln: give me 6 hours to chop down a tree, and I will spend the first 4 sharpening the axe. So I applied this rule performing the DCR surgery. The first step is the preparation. So obviously we don't perform this surgery in the acute stage. If there is inflammation, we give antibiotics and analgesics. When the situation is resolved, then we proceed. So how we prepare the surgery? So I started the preparation 20 minutes prior to execute the procedure. So I put 3 packs in the nasal cavity. One is the generalized packing. This is soaked with adrenaline and xylosine. It's a decongestant and it gives an adequate exposure to work in the nasal cavity. So other is targeted packing, and this packing is, this is a Marisol dressing. This is a foamy dressing soaked with decongestant spray, adrenaline and xylosine. So I put this pack in the site of, targeted site of the lacrimal region. So I put it, I rub it on the mucosa, so the affected mucosa is decongested and gets shrink. So this 20 minutes preparation is extremely helpful to proceed the further steps. In the next step is the exposure. So after the decongestion and shrinkage of the sinonasal mucosa, this is the good exposure to work. You can easily see this is the middle turbinate. This is a pointer. So this is the endoscopic view of the nasal cavity. This is the middle turbinate. This is the attachment of the middle turbinate, and this is the inferior turbinate, and this is the lacrimal sac region. So you can get this picture after proper decongestion and the vasoconstriction. So after the preparation, I used to inject in this region for the preservation and for the elevation of this flap. So routinely we use the 2% lidocaine with adrenaline, and this is injected and then wait for 5 to 10 minutes so that all the absorption of the injection get its work. The third step is the incision. So the excellent instrument for the incision is the cataract knife, because it is available in, one is the straight, other is angle. But we use the number 15 blade. The first incision is given at the middle third half of the middle turbinate, and the direction of the incision is upwards up to the soft tissue or the aperture of the nose. So this is the first incision, and my second incision is above the attachment of the middle ear. So this is second incision, and after that we join these two incisions. So this is the adequate exposure of the sac region. The next step is the creation of the flap. So mostly we use the Carrison. This is the Frere elevator, or you can also use the frying pan. This is a very important flap. So we have to raise this flap, and this flap must be preserved to cover the ragged or sharp edges of the bone later on when you open the sac and remove the bone. So you have to preserve this sac, this flap. This is very important flap. I will show in the next slides. The next step is the removal of the bone. So actually this is a very important step, because you have to expose whole the lacrimal sac. I can say we have to expose the whole lacrimal apparatus. So I start from the NLT nasolacrimal duct, dissect whole the sac, and above up to the region of the common canaliculus. So later on follow-up, you see this new ostium is visible, and this is the key to success for the successful DCR. This is the exposure of the lacrimal sac. You know, this is very thick sac. You have to expose all the thin layers and all the debris from the sac region, so the whole sac is visible. And yes, you can see this is sac and this is whole sac. We have to expose and remove almost all the bone from the upper part and as well as from the medial portion of the lacrimal sac, because when you have to create the lower flap, this portion goes downwards into the nasal cavity or into the middle meatal region. So after the exposure, the next step is the incising. So you can use the cataract knife. I use the number 12 or number 11 blade and open the sac from it, starting from the NLD region to upwards high up. So you have to expose, or you have to open all the sac region. And the next step is the creation of the lower flap. So these flaps are cut horizontally, and this is the lower flap, and this flap is placed on the side, nasal side of the nose, or you can say on the middle meatal region. And then the next step is the creation of the upper flap. Upper flap is, I mostly use the sickle knife, and this instrument is used in the ear surgery, and this is the creation of the upper flap. So when you create the flaps with the help of eye colleagues, I used to wash the sac. This is the region of the common canalicus. You can see the well drainage of the saline, which is washed through the punctum, and there is the exposure of the common canaliculus. The next step is the Mayer splication. Initially, which I mentioned, the flap, the mucosal flap, it is cut into two. This is the lower half of the flap, this is the upper half of the flap. So what we do in the next, the upper flap is placed on the lacrimal sac, open lacrimal sac, and as well it is placed on the sharpened edges of the bone, so that it will cover the sac region as well as on the rag bone or neck bone, so that it cover and it nicely epithelize later on. The last step is the to pack or not to pack. Usually such surgeries don't need to pack because there is no much significant bleeding, and I used to put the sponger stone, and sponger stone is a very good material. When it is placed on the operated side, it gets swell up and it adherently stuck to the operated area. So such patients don't need to pack in the final step. So the last debatable issue is either stenting or not to stent, and I usually do not stent the DCR surgeries, especially if we do the endoscopic DCR. And I'm sharing this meta-analysis of a huge number of patients, 1,017 patients, and it also shows that the significantly better outcome in the external DCR with stenting, but not in endoscopic DCR. And either stent or not to stent, it is a tailor-made decision. And every patient don't need stent, and you can decide perioperatively, or you can decide on the decision or at the step of syringing and probing. So EDCR is a truly rewarding procedure, and cautiously follow all steps as they are crucial and integral steps for the better outcome. So any question? I think my time is over.
I think we'll leave the questions till the end, please.
Okay, sir.
Yeah.
Thank you so much.
Thank you, Dr. Fraz. Thank you all for coming here for this early session after 2 long busy days. So I will try to make a quick review of the evolution of DCR technique, and I will try to make a comparison of 3 most commonly used techniques for duct recessive rhinostomy. So we all know that the most common technique that we have used was external DCR. It has a very long history. It started 100 years ago, and since 1920 there hasn't been too many major changes in the technique. And
has a very high success rate, is accepted as the gold standard. But of course, evolution continues, and patients want to have less skin scarring, have a faster recovery, and as surgeons, we want to protect the lacrimal pump function, also have a high success, less bleeding during the surgery, have a short operation time, easy surgery, and also we don't want to have any complications. So endonasal DCR, as explained very well by Dr. Latif, is actually much older than external DCR, but it was not popularized until the 80s, until the high-resolution fiber optic endoscopes and endonosal surgical instruments were available. During that time, in the beginning, the success rate for endonasal DCR or endoscopic DCR was not as high as external DCR, and this was linked to the ostium size, because with the external DCR, you can create a very large ostium and osteotomy, and this may not be always possible with an endoscopic DCR. But all the studies done in these years on endoscopic DCR are referring to the study from Lindbergh from 1982. And Lindbergh made an endoscopic view of the external DCR cases, and he found out that after the healing period, the actual ostium size is averagely 1.8 millimeters, and that doesn't have a negative effect on the success. So right now the technique has evolved and it has progressed and has a high success rate like external DCR. With the 90s, laser was available as a new hope for lacrimal surgeons. In 1990, first by Massaro, and then in 1992, Levin used the laser for dacryocystorynostomy. Massaro preferred an endonasal approach. Levin tried the endocanalicular approach, which was more familiar for ophthalmologists like us. And the story started first with lasers that we know from ophthalmology, with YAG lasers and argon laser, but the success rate was very, very low in the beginning. And with the year 2000, with alloy, diode laser was introduced. And with the use of diode laser, the success rate went higher. And after 2004, the reported success rates were around 80 and 90%. Diode laser had some advantages over the other types of laser, like having the ability to deliver high power laser energy over a very narrow probe, and supposedly should have less heat and less thermal damage. And its design is very compact, it's almost portable, and has low cost and low maintenance expenses. So we started the laser DCR procedures in 2009, but you can see here, still with diode laser, you can have very severe charring during the surgery, which you have to clear mechanically. But this shows that there's a severe thermal damage on the mucosa, and this, burn scars are the worst among all the wounds. And we use mitomycin C and silicone intubation in all of these cases. When we look back after 2 years on our results, we saw our results were not as good as the previously reported as reported in the previous studies. Our 2-year anatomical success was 68%, and real functional success, which is the important one, was only 60%. So we went back to these failed cases and made nasal endoscopy to find out what the reason was. And in most of them, in more than 60% of them, the reason was that as you can see here, can you see the cursor here? Yeah. The ostium was healed by mucosal proliferation. And in 20% of them, there was a synechia between the middle turbinate and the lateral wall. And in 14% of cases, there was a false ostium. Here you can see, where's my cursor? Yes. Here you see a large ostium, but this is actually not the lacrimal sac inside. This is an ethmoidal cell located anteriorly, and during the surgery, we didn't recognize and first went a very small hole on the on the lacrimal sac went to the ethmoidal cell and made a large osteotomy on the lateral nasal wall. So the real osteum is here inside that, and it's very small. That's why it's not functioning. Also, there was 8% of functional failure in these cases, which means they were patent on irrigation, but they were still tearing and had delayed dye disappearance test. As you can see here on this one, when you are working only just using the laser and not using any mechanical instruments, the osteum you get is wide superiorly, but gets narrower when you get inferiorly. And this heals up very fast, and eventually it ends up with an osteum located superiorly, and you have a sac underneath that still keeps mucus and tears and causes inflammation and tearing. So this is the Sump syndrome. We looked also these cases with lacrimal endoscope, and you can see here on this one, let's play it again, that in the osteum you are seeing some septa. Yeah, okay, thank you. Some septa which were causing resistance to tear drainage. Also, in some of them, the osteum was like a valve, opening with pressure and was closing when the pressure was gone. So the tearing kept continuing. The most common complication that we saw was stent dislocation, but less but more important was canalicular and punctal problems. In this study group, we saw only in 3% of them, but afterwards we saw many patients referred from other doctors or from our later cases with severe canalicular problems. And this is a very important issue because a failed DCR you can correct with a new DCR. But if you get a canalicular problem, these patients are stuck with Jones tube, which we don't like very much. And there was one orbital emphysema, which can be seen in any type of DCR. This was an interesting case where we learned a lot from. So this patient was referred to us after a failed endoscopic DCR, and we made an uneventful, very simple laser DCR in this case. And we didn't notice anything wrong. But after the surgery, the patient kept tearing and was not happy. And we went back to make a resurgery 1 year later. We saw that there was a big dacryolyte blocking the osteum. And when we removed the dacryolyte, the problem was solved. And if you look at this, you can see that the dacryolyte was already there during the first surgery because we went through that with laser and intubated over that without even realizing it. So if we are going to do any transcanalicular DCR procedure, it's very important to use a DCG or CT DCG to rule out the filling defects, because dacryolyte is relatively benign, may not cause any problems, but if it's a tumor, you can go through that with the laser. And there's another study we made in cases with functional epiphora, comparing the same 3 groups of DCR. And the result was very surprising for us, because the groups were laser DCR, non-endoscopic endonasal DCR, and external DCR. And the highest success rate was seen with external DCR, over 80%. I think there are 2 things important in this study. First of all, in the beginning, all these patients were patent on irrigation. There was no anatomic block. But in laser DCR patients after the surgery, there were more than 10% of patients with an anatomic block, which means they ended up with a worse condition than they were before the surgery. And we had no anatomic block in external DCR, and I think this was related to the flaps that we have in external DCR surgery. And there's a second point that's important and interesting. This is showing the functional success of the DCR technique, and it was highest in external DCR, which is usually not expected. And I think the answer lies in the technique that we are using. There's a study from 2010 that says that preservation of the lacrimal sac wall attachments at the end of external DCR to the medial canthal tendon, orbicularis oculi muscle, and lacrimal diaphragm allows the lacrimal pump to function more effectively. We do our incision always in the nasojugal groove below the medial canthal tendon, and we try to make a very small 8 to 10 millimeter incision. And we never detach or cut the medial canthal ligament. And at the end of the surgery, when we are suturing the flaps, we always suture the flaps to the overlaying orbicularis muscle to preserve the lacrimal pump function. And with this technique, we usually don't see any visible scar. There are some meta-analysis, this one is from 2020, which compares the three techniques. And here you can see the result that the external DCR and endonasal DCR have similar success rates. But the success of the direct laser DCR is lower than that, 80%. But that's the average. I think there's something more important about that. When you look about the results after 2020, you see that the reported success rates have a range between 30% and 85% or sometimes 90%. But you don't see that now with endoscopic or external DCR. In most of the studies, the reported success rate is around 60% and 65%. I think this shows us there's still something not standard in the technique that's being used for the laser DCR surgery or in the type of the laser, because it's not standard. Not everybody gets the same result. So as a take-home message, I want to say external and endonasal DCR are both the gold standards now today, and laser DCR outcomes vary due to technique and device differences. If you're going to do laser DCR, you have to rule out any intrasacral pathology before, almost. And also, if there's a canalicular problem, that means you change a distal NLDO into a proximal NLDO, which makes the treatment much harder and much more complicated. So thank you.
Bismillahirrahmanirrahim. I am Dr. Sadullah, Associate Professor at Al Shifa Trust Hospital, and my talk is on Lester-Jones tube. This is the sequence of my presentation. So Lester-Jones invented this technique in 1962, and these are for patients with severe epiphora due to proximal canalicular obstruction when the DCR is not possible. He wrote a book on this in 1976. This is he performing the surgery. These are the tubes who were made by himself. Lester-Jones tube, it's a Pyrex tube, and which is about 14 to 22, 24 millimeters long, and inner diameter is about 1.5 to 1.7 millimeters, and the outer diameter of the tube is 2.5 millimeters, and the flange is of 3 to 4 millimeters. These are the indications for this surgical technique when there is complete proximal canalicular obstruction, and in congenital cases and post-traumatic, and when this area is having some tumor or post-radiation canalicular stenosis. These are some contraindications when we don't have a good space in the nasal cavity and we need help from the ENT specialist, and we can't do this surgery without their help, and after an active infection or the eye is very dry. These are the surgical steps which we do in the surgery. I'm going to show you in a video. This is the post-op care. We need topical antibiotics and steroids, and regularly washing of nose with saline or just water. And we ask the patient not to blow the nose for 1 week. These are some early and the late complications. In the early complications, we may have bleeding, but by packing the nose and preparing the area good, we can avoid this. Malposition is also an early complication, but we found that migration in our cases, in 3 of our about 20 cases, biofilm formation is another complication. This is a video. I hope there's a sound in it, and we will play it. This is our recent surgery. He's a doctor by profession, and he came with epiphora from both eyes with a complete blockage of the canaliculus. Just a sound आवाज नहीं आ रही इसमें.
Presented with bilateral. Lester John tube.
इसको इसके साथ करते हैं तो साउंड. सर ये हो जाएगा.
Was previously placed on the left side, and this video demonstrates the procedure on the right side. The procedure begins with nasal packing. An eyelid speculum is applied, and lignocaine with adrenaline is infiltrated into the region of the caruncle. Carunculectomy is then performed using Westcott scissors, and any oozing blood vessels are carefully cauterized to achieve adequate hemostasis. We now move to the endonasal view on the right side. Here the middle turbinate and the middle meatus are identified. The middle turbinate is gently medialized using a freer periosteal elevator to expose the surgical field and allow safe access to the nasal cavity. At this stage, I am showing a gauge and a 20 mm sizer from the LJ introducer set. The dilator is placed over the trocar. First, the trocar is introduced at an angle of about 40 to 45 degrees along the contour of the upper lid, followed of the dilator over it. The position of the dilator is simultaneously confirmed on the endoscopic view. After this, the dilator is removed. The measuring sizer of 20 mm in length is then introduced. As 4 rings are visible internally, this confirms a tract length of approximately 16 mm. Based on this measurement, an approximately sized tube is selected. Here a 20 mm stop loss tube, Lester-Jones tube is mounted over the measuring gauge. The measuring sizer is now removed over the trocar. Previously, we encountered episodes of tube dislodgement in few patients. Therefore, a 6-0 proline suture is placed circumferentially along the carunculectomy site to provide additional fixation. The Lester-Jones tube is then inserted over the trocar with gentle but firm pressure applied using the thumbs. Tube patency and position is confirmed by irrigating with saline, which is seen to flow freely through the tube into the nose. The tube is then secured with previously placed 6-0 proline suture, and this is buried using 7-0 vicryl for patient comfort and stability. A final saline irrigation on the right side is performed. The left side, which was previously operated upon, is also checked. After removing small amount of secretion, irrigation confirms free flow through the tube on that side as well. This completes the procedure.
Thank you very much.
Thank you, Dr. Saab. Next speaker is Dr. Rashid Beg.
Today I am presenting my study on functional outcomes of external DCR versus endonasal DCR. It's a cohort study which was conducted at the Akhar University Hospital, Karachi. So I'm thankful to my colleague Dr. Sarfraz. He has very well elaborated and described the procedure, how to perform the endoscopic DCR. So there is nothing to disclose in this presentation. Nasolacrimal duct obstruction is a common cause of debilitating epiphora. More or less 3% of patients presenting to ophthalmologists have this complaint. This causes tear stagnation, leading to recurrent infections and acute and chronic dacryocystitis. The surgical solution is DCR. The goal is to create a dual patent drainage pathway from the lacrimal sac into the nasal cavity. There are two main approaches: external DCR, which is a gold standard. We have direct visualization of the sac via skin incision. In endoscopic DCR, it's a scarless, no skin incision via the nose. The advantages of external DCR is direct visualization, high success rates, less dependent on expensive technology. The disadvantages are skin scar, potential damage, and to orbicularis oculi muscle. The advantages of endonasal DCR is there is no external scar, faster recovery, preservation of lacrimal pump anatomy. The disadvantages are steep learning curve, requires specialized endoscopic equipment and skills. The debate here is which technique yields better functional outcomes. As we search the literature, in 2021, Tariq et al. Reported that endoscopic DCR has 76.7% of success versus external DCR 73.3%. In 2020, Coraso mentioned that external DCR has 86.4% success versus endoscopic DCR, which is 73%. In another study, Baranikana et al. Mentioned endoscopic DCR has 93.6% success versus external DCR 62.4% success. So our goal is to provide a clear comparative analysis of functional success, epi-4A resolution in our patient population. The objective of the study is to compare the post-operative functional outcome of DCR performed by external versus endoscopic approach. The primary endpoint of this study is the resolution of epi-4A assessed post-operatively at 1, 3 and 6 months. It's a retrospective cohort study conducted at the Aachen University Hospital between March 2018 and March 2024. Participants were included adults between 18 to 70 years of age with acquired NLD obstruction. Those patients who have previous DCR, trauma, congenital causes, lid abnormalities and tumors were excluded. We have 90 patients, sample size of 90 patients, 40 in endoscopic group and 50 in external group. Overall, mean age in endoscopic DCR is 47 to 20 years of age. In external DCR is 43.4 to 22.6%. Mostly females patients are, we found that females are more, have this problem. So 61%, overall 61% of patients are female and 39% of males. Mean symptom of duration is 28.5 months to 45.53 in endoscopic DCR. In external DCR, we have 40.5 to 60.2 months. On presentation, in external DCR group, 100% patients have epi-4A, 42% have active infection, 38% have chronic infection, and patients with endoscopic DCR as 97.5% has epi-4A complaint, active infection in 45%, chronic infection in 47%, and recurrent infection in 35%. So primary outcome that is a functional success at 6 months is external DCR have 86% after the 6 months of procedure, and in endoscopic group is 87.5% in endoscopic group. Endonasal DCR, we have 40 patients. Successful recovery is in 35% patients, 35 patients, which leads to 87.5% success rate. In external DCR, we have 50 patients. Successful outcome is in 43 patients, which goes to 86%. There is a temporal pattern of symptom improvement. As we see, there is a progressively improvement in the symptoms, and at 6 months post-operatively, 87% are in endoscopic group and 86% in external group. Secondary outcomes, active complaint, redo surgery and post-operative complications occur in 1 patient with endoscopic DCR and 3 patients in external DCR. There is a need for redo procedures in 7.5%, 3 patients in endoscopic group and 1 patient in external group. So our key findings are endoscopic DCR and external DCR have equivalent functional success rates in our cohort. And this is in alignment with the literature. The finding is consistent with several international studies, as I showed you before. So both endonasal, endoscopic and external DCR are highly effective and statistically equivalent procedures for the treatment of primary acquired NLD obstruction in terms of functional outcome. The choice of procedure should be individualized. Decision factors can now focus on surgeon expertise and preference, patient preference, example, desire to avoid a facial scar, resource availability, endoscopic equipment. Endoscopic DCR is a valid and powerful first-line surgical alternative. The choice between endoscopic DCR and external DCR should be guided by clinical context and preference, not by an assumed difference in efficacy. Thank you very much.
For general anesthesia, is endoscopic DCR easily done under local anesthesia in the house?
Endonasal, without the endoscope, is what I do.
Yeah.
Endonasal, you can do it, and especially select patients under IV sedation or even local. You can probably do it if you do the right blocks.
Right.
But after this, because it's a very quick.
It's a very quick, maybe like, if a 7, 8, 9 minute procedure, if you really are past your learning curve, right? So you could probably do it. I mean, yeah, if need
Anybody else agrees?
Experience doing endonasal under local anesthesia, so I don't know whether it's possible or not.
Jan?
So you had not, or you have?
No, I don't have any experience doing it under local anesthesia.
Because we all do under local anesthesia, we can do under local anesthesia, external DCR, but not endoscopic one.
But not endoscopic.
Sadhula? Yes. Ji.
Sir, I think so. Endonasal DCR, if you are doing in local anesthesia, is not safe surgery because you put the 4% Xylocaine and it anesthetize your larynx and your oropharynx, and patient can inhale the blood. It's not safe procedure. If you want to proceed with the endonasal DCR, it's safe to do under general anesthesia.
Yeah, I would like to. Probably the reason I have never ventured or had the courage to do it under local anesthesia.
Yes, ENT person is saying that probably must be true. But we do external DCRs under local anesthesia, and we do give them nasal packing and everything.
I worked with Matthew Young, who was the pioneer in endoscopic DCR, and he was incredible. So he would do 5 back-to-back endoscopic DCRs under local anesthesia. But it also depends on the individual surgeon skills and his understanding and availability of the resources. So I believe if we have a team of ENT surgeon and the oculoplastic surgeon working together, then it may be safer. Otherwise, it's a bit tricky.
Jan, do you have any experience?
To be honest, I do both external and endonasal DCR with GA. I had to do some couple of cases with local anesthesia and they were fine, but I don't prefer because I think it's more comfortable for the patient and for me to do it under GA.
Right. Sadhula, he was doing it with a G.
मोस्टली मैंने भी मतलब GMEs किए हैं लोकल में एक्सटर्नल DCR क्योंकि ज़्यादातर प्रोसीजर एक्सटर्नल में हो चुका होता है बोन को निबल करने से पहले और उसके बाद म्यूकोजा जब इंटैक्ट है तो फिर आप एक्सटर्नल कर सकते हैं लेकिन मोस्टली आई आल्सो प्रेफर टू डू इट अंडर GA नॉट अंडर
No problem.
Right. Okay. So that we agree on. I thought आप जो कर रहे थे stop loss वाली that was under local. अरे जी ऐसे लग just because you're injecting local I said तभी मैंने पूछा. So I think probably the transcanalicular is the only one you can do under local anesthesia.
No, I don't do transcanalicular anymore. But when I used to do that, I also did that under GA.
Oh, so you
no.
Your preference was not for
yes.
So what problems do you think you had under local anesthesia? Too much pain probably for the patient?
Can be painful.
Right.
Also, if there's bleeding, it may take more time.
Right.
And when you do I don't know how you do it, but if you do the transcanalicular DCR, you usually need to enlarge the ostium with mechanical rongeurs, and I think it's much easier to do under GA. But that's just my, this is just what I'm used to maybe. Once again, I had to do that under local in a couple of patients, and there was no problem, I agree.
Yeah, the major challenge with transcanalicular DCR is the success rate is not very high. It probably doesn't go to more than 50 or 60%. But patients who are very old cannot get under general anesthesia. They get recurrent inflammation. Probably that was the patients which are very useful. And sometimes patients probably who have got a mild degree of epiphora recently did. Well, these are ophthalmologists, and he had a mild degree of epiphora. He couldn't operate and couldn't do anything, and he had some bit of canalicular obstruction as well, and he was able to do that, and it released his problems in that way. But I tend to do it all under local anesthesia. Probably need to re-enhance with lip block, nose block from the outside. The bleeding is less. In order to make it bigger, you just go straight in and then sort of slide the laser thing up and down so that it sort of enlarges the ostium in that way. Because there are studies that you can make the flap with a knife as well, and then cut the bone and just do the internal osteotomy with a laser, like the lacrimal flaps make with the laser. Those are the other things which you can use, and then to complement this with probably mitomycin or Canacort, that is another thing which can be done in that sense. But I think it's probably not the standard of care for all of the patients which you have, but it is something which is a tool in your armamentarium, especially in patients who have got sort of failed those obstructions. If somebody doesn't have a Sump syndrome, probably if this is just fibrosis, you can use that to enlarge that ostium over there with the laser, that rhinostomy over there. मेरा टाइम हो गया, हमने बेल बजा दी. ठीक है. Thank you.
I think as Jean pointed out, you get a lot of scarring, burns with the laser, and that's the worst type of healing that you have, and usually you get an over fibrotic response.
Case of doing it, but not very. This is I think all the big topics in the canalicular nasolacrimal system have been covered. Just teeny bit is left. It's a bit rare, but it's a real challenge if you get it. Inflammation of the canaliculus itself. So how many of the audience have seen canaliculitis? Quite a few, quite a few. So it is not uncommon. You already have been. So the primary canaliculitis is usually inflammation of the canaliculus itself without any known cause, and in the secondary there is some inciting agent, maybe some foreign body. In the chronic ones, it is the actinomyces israeli or pseudomonas. It's pretty painful and chronic. They suffer for years before they come to the oculoplastic surgeon or the more precisely dacrayologist. And this is what they look like. In my experience, mostly I have seen them in the upper lid.
I've seen it in the
lower lid, but दोनों में हो सकता है. So you can start with the topical treatment, moist compression, and mostly these are not useful, and they have already been through this. So the real work is performing punctoplasty like with caniculostomy, and do the curettage to remove all the material which is lodged in the canaliculus. So this is the technique. We'll show you a video. It was made when I was working at Mayo Hospital. ये play करेंगे. Play करेंगे. I use the smallest available needle to give local anesthesia because it is less painful for the patient. And do not just inject it at a high speed, just slowly infiltrate. So first we perform the punctum dilatation. You can imagine this is already inflamed, so giving local anesthesia is not that easy. Westcott scissors is pretty good, so you can make a long canaliculostomy, and you can see that that's the material starts coming out. And you are sometimes surprised how big it is sort of dacrolith, isn't it?
Sulfur granules.
Sulfur granule, but look at that. They lump to form big balls sometimes. That's a big ball. Can you imagine? So you can send it to the laboratory, but mostly they just come out with the calcium.
Which antibiotic do you flush?
I flushed with the pyridine solution. Right. So that was the presentation, but I would take this opportunity to thank you all for attending this Lahore Ophthalmos, especially the oculoplastic session. It was a great success. I'm thankful to the chairman of the scientific committee, Professor Mean. Big hand for him. Because he gave us enormous support, considering that he was looking after the whole scientific program. So we had 103 presentations, 53 speakers, 11 sessions, 6 symposia, and 5 instruction courses, and they were pretty well attended. And I'm really grateful to Turkiya. Is that correct pronunciation? Turkiya, UK.
Why is this Lifetime Achievement Award? And आपको भी आप इधर आ रहे हैं Lifetime Achievement Award. हाँ सलमान हमजा सलमान आप भी आ रहे हाँ I think this is the जिसको कहते हैं ना there is always man behind the gun. So he was the man behind this all big guns that he was running around to get the burnout. So inshallah we'll continue that, and Professor Ibrad, please past president of the POA, and he's going to invite you for the Yasir Aji. बल्कि सारे आ जाएं आप लोग we have a book. सारे बराबर ही हैं आगे से बात आगे इधर आप बच्चे पढ़ रहे हैं हाँ सारे ना से ले आगे बाहर
हेलो
अच्छा लीव अनाउंसमेंट एक सुनने बोलिए
इंशाल्लाह नेक्स्ट मंथ जनवरी 23rd to 25th पेशावर में ये कॉन्फ्रेंस हो रही है तो उसके लिए मैं सबको इनवाइट करता हूँ.
Ready?